First, thank you all for joining me to discuss today's topic, supraglottic jet oxygenation and ventilation, SJOV, in deep water airway management. This is my financial disclosure. My institution, University of Pennsylvania, was established in 1740 by Benjamin Franklin, whose head photo is on the US $100 bill. UPenn is America's first university, first medical school, first hospital, first teaching hospital, that's my hospital, first business school, Watson Business School, and it also produced the first computer in the world. Up to now, there are 29 Nobel Prize winners from UPenn. We all know that Michael Jackson died of propofol infusion for treatment of amnesia. As anesthesiologists, we can easily understand that after propofol injection, infusion, you can see it like these patients with GI endoscopy, after propofol injection, OT stat will quickly drop to about 86. Then I have to use SJOV technique to maintain oxygen above 90 or to 96 again. And although the patient has a nasal cannula with 10 liter per minute oxygen supply, it is coming up after using SJOV, gradually back to normal to 96%. This is another example, a morbid obese patient with a body weight of 365 pounds. For ERCP in prone position, we use IV propofol and ketamine infusion. Then we also use SJOV technique with a manual ejaculator, the driving pressure around 15 psi. This is a regular suction catheter and also as a nasal cannula. So we use this technique to maintain this patient a normal O2 state during propofol infusion for ERCP procedure. This is another example that morbid obese patients receive cardiac catheterization, but patient first receive sedation but disinhibited moving around. So we use SJOV technique like the earlier patient and give SJOV to maintain patient O2 stat in normal level and the propofol sedation. So basically, you can see this is the SJOV assembly we used earlier in two patients. And this is the first generation of we nasal jet tube or WNJ. So this is second generation of WNJ, and you can see the jet channel and build in the lumen in the wall of the WNG and open the distal end and provide SJOV. There's also another channel built into the wall and open in the middle of the lumen of the WNG that monitor anti-CO2, the breathing. From this video, this is from GI suite. When we do GI endoscopy, you see the SJOV inject a high flow, high speed oxygen flow close to vocal cord or into the vocal cord that maintain oxygen level and the ventilation. So in 2018, the anesthesiology news report the study from China that using SJOV during upper GI endoscopy to reduce hypoxemia. These patients end up propofol sedation. And you can see that compared to nasal cannula oxygen supply in about 600 patients, the SJOV significantly decreased hypoxemia rate from about 9% to about 2.7%. The side effect, the most common one for SJOV is dry mouth. Usually mild, quickly recovered, but there's no barotrauma, mean the life-threatening barotrauma like pneumothorax, etc. This is the case, patient morbid obese with BMI 54, and patient refused a week follow-up intubation, and they tried mask ventilation, the propofol any sedation or anesthesia, use the video larynxoscope to intubate, but they failed. Then the patient, he said to O2 set as low as 75%. Then they quickly started SJOV using WNJ and it quickly reached the O2 set to 100% in a minute. They maintained this as a O2 set to 100% for 7 minutes in this paralyzed patient, and did a successful fiber optic intubation. The blood gas after intubation is basically normal. In recent study, they compared the O2 set, the hypoxemia rate in the morbid obese patients receiving propofol infusion for hysterectomy. They compare the 3 technique face mask, nasal oral oxygen, and SJOV. You can see compare the face mask or nasal oxygen, nasal cannular oxygenation. The hypoxemia rate significantly decreased from around 30 to about 6%. This new study from Dr. Ping Chia also using WAG for the bronchoscopy examination, the lung biopsy. They typically use localization of the airway and sedation for this procedure. But that patient is a lot of hypoxemia and a lot of coughing. So they using this technique and using the fiber optic examination through the major lumen of the WNJ, and they also provide SJOV and breathing monitoring. You can see that they are this technique significantly decreased hypoxemia rate from about 24% to about 11%. And the major complication of SJOV or is the mild dry mouth. And Dr. Xia and his group also studied the gastric volume at the different level of driving pressure, up to 30 in the up to 25 using SJOV to see whether SJOV increased the gastric distension. In this study, it basically showed only at driving pressure 25 psi, it may significantly increase the gastric volume from 2.72 to 3.7. In our institution, we have a lot of patients suffer from TMG. Basically, patient cannot open mouth, and they receive the surgery to increase the opening of the mouth and the general anesthesia. We typically use a week nasal fiber optic intubation, but for recently we increasingly use the sleep fiber optic intubation by using SJOV in the paralyzed patient to maintain patient oxygen ventilation using one side of the nose This is a patient, the stomach always open to make sure there's no gastric distension. So on the other side of the nose, you can do the fiber optic intubation, but this is sleep fiber optic intubation in a paralyzed patient, and you can use as much time as you need. And this is we use SJOV in the patient with vocal cord polyp resection. Typically, they use a small tubing and to do that, but that will affect the procedure. Now they use SJOV with WNJ. It significantly will facilitate the procedure without hypoxia in a paralyzed patient. TTJV is the last step in ASA guideline, still at this time, to save the patient cannot intubate, cannot ventilate emergent difficult airway. However, how many of us, even experienced anesthesiologists, had experience using TTJV in emergent, even in the elective case? So who are comfortable or confident to perform successful TTJV in emergent difficult airway? This is like the airplane is crashing and you have to jump out of it to save your life with a parachute, but you never used parachute before. No experience on that. And also in the emergent difficult airway, typically you already try to intubate a couple of times, maybe using video endoscope or other techniques. So the upper airway already have significant edema and closed upper airway. So if you do a TTJV like this boy, constantly inflate air into the balloon and rupture. In patient, we cause barotrauma and patient die. Dr. Ping Chia learned SJOV technique in the national training class, and he buys the manual detonator and practice this assembly for SJOV in the elective case for 2 weeks. And then the department had this patient had a big thyroid for thyroidectomy, but the patient had cumulative airway. Supposedly, he should receive a week fiber optic intubation. But the patient attending, I think she has video endoscope, so she induced and paralyzed patient, easy ventilation, but she grateful view of glottis. She tried twice intubation, but cannot intubate, and patient become partially difficult to ventilate. And then senior anesthesiologist tried lighter one more time, failed, and patient cannot be ventilated, must ventilate anymore, and become emergent difficult airway. And they emergently called surgeon for tracheostomy. At the same time, Dr. Xie started SJOV quickly and increased the oxygen level to 85% in 3 minutes. And then they maintained this oxygen level above 90% for 45 minutes until patient wake up and a muscle relaxant is gone, and patient is survived this emergent difficult airway without any brain damage or the major complication. So compared to TTJV, previously SJV had jet pulse above vocal cord, so this is non-invasive, easy to teach and train in patients, elective case, and low intracranial intratracheal pressure, so that would be minimal barotrauma rate, and also is a high successful rate, especially if you have a training in elective case, not like TTJV has a failure rate of 64% and barotrauma rate 30% in emergent difficult airway management. Complication of SJOV including minor nose bleeding, dry mouth, sore throat, barotrauma, and the new studies show probably SJOV driving pressure should be below 25 to minimize the gastric distension. Relative contraindication is significant nose bleeding, upper respiratory infection, existing barotrauma. Keeping in mind, if the patient die, these are still relatively complicated. If you can still use it in this situation to save the patient first. So compared to SJOV or using high flow nasal cannula, the SJOV has a high flow at a high frequency, at a high driving pressure, at prolonged apnea time, at open and close, both open and closed mouth. But HF nasal cannula majorly in the closed mouth. It has effective ventilation and relieve every obstruction because it's a nasal airway. This is the comparison between SJOV and SJOV in a recent review article. In the detailed comparison between two techniques. Thank you very much.